Okay, fantastic. So it should be recording now.
Cool.
For
I
some reason
think
your screen's not
we should give
showing.
it a start.
Yeah, definitely. So,
Okay.
thank you everyone for joining us again for episode 2 in our Road to the PSA series with MedEd. It's really great to have Mozin with us today, who's a doctor who's actually met some other UOM students through placement and is just really keen on teaching and has very kindly come in to teach for us as one of the resident doctors at MFT. So thank you so much, Mozin. And I hope you get a lot out of the session, everybody. And before we start, I've had a lot of questions about recordings and slides from last week. I've been explaining to people that we've had sort of a ballpark 200 people making that same request. So we're trying to find a way to sensibly distribute things and get the YouTube out, but also make sure we get fair feedback for the doctors that have put the work in for this and make sure that this is reflected as a national series that they've designed and delivered for their specialty training. So that'll be done by the end of the week. But thank you for your patience. You will get the recordings, you will get the slides. It just might be another couple of days if that's okay. So thank you so much. And yeah, Mozin, over to you. Thank you.
Hi. Hi everyone. So my name's Mohsin. I'm one of the F1s. I work at the Royal Oldham Hospital currently. My current rotation is orthogeriatric, so looking after old people with hip fractures and things like that. Quite complex comorbid patients, often coming on lots of medications. So we'll do our session today on prescribing in elderly people, and people with renal impairment. So hold on. So I guess from feedback from our last session was that people wanted like tips and tricks and how to actually navigate the BNF rather than just prescribing. So I'm just going to go through a few of the tips and tricks that I think will be very helpful to you guys. So first thing I'd say is get used to using keyboard shortcuts. Control C and Control V on your keyboard. I'm sure most of you already know about this, but um, get used to quickly copying and pasting things. It'll save you a lot of time, especially between the prescribing window and the BNF. If you quickly paste in drugs into the search bar to check them or check it in the page. Um, I'm not sure if any of you know this, but you are able to split screen in the exam, so you can have, if you drag like the windows, you can drag the BNF to one side of your screen and the BNF to one side of the screen and the PSA exam on the other side of the screen, so you can have them side by side. So that'll save you time, like rather than flicking through the windows. Um, Control F, that's another keyboard shortcut, so that lets you find anything in the page. So if you're searching for hyperkalemia, it'll just bring up all the things that are like hyperkalemia on the page, and you can quickly search through rather than scrolling through manually. That saves a lot of time. This is another thing you can do is and or searches, and I'll demonstrate how this works. But what this essentially does is this word that's before the and, it searches all of these pages. So aspirin, allopurinol, citalopram, whatever. If there's hyperkalemia mentioned on that page somewhere, it'll bring it up in the search results. And sometimes that can be a quick way to confirm links. So what I'll do is I'll just hop out this window and go to the BNF, and hopefully it should be able to show you how some of these work. Oh, actually, I'll just show you this quickly as well. You can type Appendix 1 interactions in the BNF search bar, so that'll bring up a lot of these tables. So like drugs that cause hypokalemia, hyperkalemia, hyponatremia, bradycardia, hypertension. So a lot of the drug side effects. Now, it's important to note that these tables don't contain every drug. So sometimes if you can't find it in there, do go and double check inside the actual drug page for the side effects. But if you want, like if you're doing prescription review and you quickly want to have a look if any of the drugs cause bradycardia, for example, you can go and have a look at these tables. So I'll show you that as well. And medicine guidance as well. I'll have it. I'll show you that now as well. Hold on. So can you guys see the BNF on my screen?
Yep.
Yeah. Okay. So this is what will happen when you open the BNF. Now, in the actual PSA, you'll get a choice of using Medicines Complete or BNF. I've always used the BNF. I found it more simpler, but some people prefer to use the BNF. So I'd say if you want to explore both and see what works for you, that'll be good. And also have a good play around in the BNF, find out where things are. Sometimes things are hidden where you might not expect them to be, and it's just quite useful to know where everything is. So just talking about this like and or search thing. So what you can do is you can go into the search bar here, and you can type in, for example, hyperkalemia. Kalemia. There we go. And you can type in and then inside the brackets you can put in whatever drugs you want to search for. So you can put alpurinol or ramipril or citalopram or I don't know, rosamide. So if you click enter, you'll see that it highlights certain things. So hyperkalemia is highlighted there. It's highlighted in other random pages, but it'll just be highlighted if it's mentioned in the page. And then once you go into the actual page, it'll take you to where it says, oh, ACE inhibitor ramipril causes hyperkalemia. Now it might not work for all the drugs, but if you're doing prescription review, you can quickly, very quickly go and search multiple drugs at once rather than going into every single drug monograph and having a look. So you can do this with as many drugs as you want. So often in prescription review, there's like 7 or 8 drugs, and you can type them all in very quickly and just have that ready to go. If you want to access Appendix 1, you can just type in Appendix 1 in the search bar, because it doesn't really show as it is, and here it is. So if you scroll down, you have all the tables here. So drugs that cause hepatotoxicity, and there's loads here. So you can quickly Control F here, for example, and bring up the search bar, and you can type in, for example, ramipril, and you can search up if it causes, what different side effects it causes. So you can come here and you can see it can cause hypertension, and then it can cause hyperkalemia as well, drugs that increase serum potassium. You can also, if you're on this page, if you want to search up hypokalemia, for example, you can search that up and it'll bring it up, drugs that reduce serum potassium, and you can quickly bring that up rather than scrolling to the actual table itself, like this, for example. Yeah, sometimes in prescription review, it might ask which drugs can prolong the QT interval, and you can just have a quick look here, and that'll save you a lot of time. Additionally, there's a section on here called medications guidance. So if you go to the main page of the BNF, here it is, medicines guidance. So it has a bunch of guidance for prescribing in different scenarios. So if you have some spare time, I'd highly recommend having a good read of these. There's some stuff hidden in these that you might not expect. So prescribing in palliative care, you'll have all your opioid dose conversions here. You go down all the way. Yeah, so you have all your opioid dose conversions here. If that's a question that ends up coming up. So there's a bunch here, and you can just Control F quickly what you're looking for. Additionally, in the BNF, you can access your treatment summaries. So if you know what the condition is, but you don't know, like, for example, what the treatment is, you could go to treatment summaries, and you have a whole bunch of like ACS. If you type in antibacterial, it'll come up with the antibiotic therapies for different, for example, cardiovascular. Meningitis might be under CNS. Infective endocarditis might be under cardiovascular, for example. And all these different antibacterial therapies. So have a look through this page. There's some kind of hidden ones as well. So for like things like status epilepticus, you kind of need to like type in epilepsy and it'll be under here. The management for these conditions, and it'll tell you what drug is indicated in which scenario. There's another good treatment summary that I highly recommend looking through. It's called Poisoning and Emergency Treatment. So here you can have like the management of all sorts of different overdoses, paracetamol overdoses, specifically tricyclic antidepressants. That's another common one. And you have their like management and what to do here. So that's quite important. So I'll just go back to here and just jump back in. There we go. Sometimes it talks about medical emergencies in the community. So in the treatment summary section, there is a section specifically for medical emergencies in the community. So sometimes, for example, for meningitis, the treatment in the community is different. So it's intramuscular benzyl penicillin rather than cefotaxime. And just keep an eye out on when you're doing your exam that sometimes it says what would you give in GP, and sometimes the treatment's different. When you're on the actual BNF as well, when you're looking for side effects, it can be under different sections. So it can be under caution, it can be under important safety information, patient care advice. For example, if I just go back to the BNF and I just search up Ramipril, for example. There we go. So you see, you can, instead of scrolling all the way down, you can quickly jump to the sections. So say you're looking for renal impairment, you're looking for side effects, interactions. Sometimes it's under different sections. So have a look through these sections and like know what is kind of under them. So where to find the information quickly. For here, you can see like dose adjustments for if you have reduced renal excretion would be here. You can also click like interactions and go here. And what you can do here is you can quickly type in drugs. So if you just type in and then just click enter, then you can see like what the severity is and if there is an interaction. So you can quickly type in a bunch of drugs for Ramipril and see if there's an interaction with them. Sometimes multiple drugs will come up and you kind of have to just gauge based on severity, or like if it's like a concrete link or if it's like anecdotal, which one you have to go for. But that's rare. It's usually quite straightforward. Another tip I'd say, if you're prescribing antiemetics and patient is vomiting, you'll get a higher score if you get the route correct as well. So in people who are sick, you'd want to prescribe like either intravenously or intramuscularly, because if you prescribe oral and they just bring it back up, it's not going to be of much benefit to them. And just be careful about antiemetic choice. For example, in Parkinson's, like domperidone is preferred to metoclopramide, because metoclopramide can worsen Parkinsonism. And in elderly people, there's going to be a separate presentation about fluid and fluid prescriptions. But in elderly people, emergency fluid boluses are usually 250 ml compared to 500 ml, to avoid fluid overload in the patient, because elderly people usually have cardiac dysfunction. They might have heart failure or reduced systolic or diastolic function. So you don't want to risk overloading them. With pain, again, start simple. Stick to your WHO like pain ladder. If you're prescribing like Brufen, make sure like PP. Sometimes I might ask what you might prescribe beside it. Make sure you prescribe PPI with NSAIDs. Neuropathic pain, it'll be quite obvious in the description whether it's neuropathic or whether it's other pain, but that's your drugs for your neuropathic pain. In treatment summaries, there is a treatment summary for lower back pain. So it's NSAIDs are better for MSK type pain. In terms of antiemetics, it's nice. You can always look them up, but it's nice to just have in the back of your mind what kind of antiemetics you can just prescribe for. So cyclizine is always a safe option for most purposes. So vertigo, vestibular, or palliative. Post-op on danzatron, and then Parkinson's is one of the ones where it's domperidone because quite a few of the others are contraindicated. So we'll start with some questions. So I'll just go next. And I'll give you guys 2 minutes and I'll just pop some answers into the chat once you're ready. There we go. So I'll just give you guys 2 minutes. Five minutes actually, it's prescribing. Does anyone want to shout out before I reveal the answer what they think the condition or like diagnosis might be? Sorry, Charlotte, I can't see the chat. Is anyone?
There's no one in the chat right now, but yeah, go
Yeah,
ahead and pop answers in the chat, guys, if
Yeah.
you're comfortable to. Yeah, we've got one. Someone said query pulmonary edema.
Yeah, so yeah, you're on the right tracks basically. So it's most likely pulmonary edema secondary to heart failure. In this case, I'd look for other clues in the history as well. So sometimes like you'll have ECG changes, or they might mention like valvular diseases such as aortic stenosis that can contribute to acute pulmonary edema. Can be caused by like acute myocardial infarctions, or sometimes elderly people are just lying on the ward and they're just being prescribed bag of fluid after bag of fluid after bag of fluid, and they just slowly get more and more and more fluid overloaded. So, does anyone want to hazard a guess at what drug might be used here?
Sorry, you've got someone saying for furosemide IV between 20 milligrams to 40 milligrams. It's one answer we've got.
Yeah, okay, yeah. So I'll just move on. Yeah, so correct. So furosemide, 40 milligrams. And yeah, IV and frequency would be stat. But yeah, you're right. So if you look on the BNF page for furosemide and you go to edema, You can see, but it's initially 20 to 50. But so anywhere in that dosage range would be correct. So you can put any of those doses, but usually with like acute heart failure or acute like flash pulmonary edema, you usually just go with 40 milligrams of furosemide IV. Now, some you might not be able to find this like in the BNF. This is just one of the ones that you might need to know, like for acute like pulmonary edema. You usually just give furosemide to offload that fluid off the lungs. So just move on to the next one. Yeah, put your answers in the chat once you're done, and we'll just discuss some of them.
Someone did ask about the last one, was in just while people
Yeah.
were doing this question. Does it
Mhm.
matter if you give an oral or IV form of the furosemide for the last question?
So if you look at the indication, it depends. So in an emergency situation, IV furosemide works better, especially if they're breathless and they're desaturating as well, because they're 90% on 15 liters. So you'd probably lose some marks for oral versus like IV injection. But I guess it depends on whether it's like an emergency or whether you have more time. It depends on the clinical situation. But in that case, I would say that for the top marks, IV would be the correct route.
And then we've got some answers for this one. First one is they want to give unfractionated heparin because they've got renal impairment. They want a subcut injection of 5,000 units per dose. But someone is arguing actually because the EGFR is above 15, should be fine to give apixaban 2.5 milligrams BD. So jury's
Okay,
out. Or you've
interesting.
also got enoxaparin 40 milligrams
Yeah,
subcut.
yeah.
Um,
Okay.
so many
Okay,
opinions.
got quite the range of answers. No, that's good. So that's what these questions are designed for. To like just think of the sort of ways that they might catch you out. So in this case, I would go for unfractionated heparin. So well done to the person who said unfractionated heparin. 5,000 units subcut twice a day. Reason I would do this was, yes, there is an EGFR like cutoff of 15 in some cases, but in most cases with renal impairment, it's safer to give unfractionated heparin rather than enoxaparin. So with most cases for prophylaxis, I would go with low molecular weight heparin, so enoxaparin, unless the question mentions like renal failure or renal impairment, in which case unfractionated heparin would be the safer bet. I'll just show you quickly on the BNF where you might find like this information if you are unsure. So if you go to treatment summaries and you go to think here, yeah, venous thromboembolism. You have a treatment summary for venous thromboembolism. So in this case, the question mentions prophylaxis, so just be careful when you're looking at prophylaxis versus treatment dose. Um, so if you go to prophylaxis and you go down to surgical patients, you'll just find here that a low molecular weight heparin is suitable in all types of general and orthopedic surgery. However, heparin is preferred in patients with renal impairment. So then you'd click on heparin, and it'll just take you to this indication where it says thromboprophylaxis in surgical patients, and you'd get the 5,000 units every 8 to 12 hours for VT prophylaxis. Uh, so yeah, in this case, I would go for unfractionated heparin because of the renal impairment, and for the PSA, it's probably a safer bet to go for unfractionated heparin if, like the question mentions, renal impairment. One thing I'd make sure of, just check like the indication. So sometimes the medical like prophylaxis dose can be different to like surgical, especially when like the surgery is something very high risk, like orthopedic surgery. So just check the indication to make sure you get the correct dose. Any questions on that one?
There was one question. I was going to save it for the end, but might as well give it now. It was
Yeah.
just about, as a general rule of thumb, if you're giving heparin, do you give a low molecular weight heparin, not just for this scenario, but
Yeah, so,
generally for life to doctor?
generally in most scenarios you'd go for low molecular weight heparin. So yeah, enoxaparin sodium would be fine for most cases, unless there was like a degree of like renal impairment, in which case unfractionated heparin would be a safer bet.
Thank you.
No worries. I'll just move on. So yeah, I've just got that screenshot there as well, but you'll find if you're ever stuck on VT, there is a treatment summary, and you'll find for most things there's always a treatment summary. Like one thing about the PSA is like it's just really about how well you can navigate the BNF effectively. So I would advise that in your free time, just go through like BNF and especially the treatment summaries and have a good look through them. Next question. Can you show to get the interactions check up? I'll show you. I'll show you afterwards. Towards the end. Oops. Sorry, I think I accidentally revealed it. But does anyone want to guess what the condition was?
We've got two people saying giant cell arteritis, temporal
Yeah.
arteritis.
So that's correct. Yeah.
Four people.
Yeah. Yeah, that's well done, guys. So that's correct. So you've got quite a few clues in this stem. So they've got like symptoms of like polymyalgia rheumatica, which temporal arteritis is also linked with. If you look at their bloods as well, they've got a raised ESR. They've got tenderness when palpating over the temporal artery, so that's correct. Afsana, yeah, she does have polymyalgia rheumatica as well. So there's quite a few clues there. Does anyone want to guess what drug would be given here?
Accidentally showed my face. You have one person saying 40 milligrams oral prednisolone daily long term.
Yeah, so that would be correct. So I'll just move to the next page. So yeah, so for GCA you would use prednisolone long term. You can see like when you go on prednisolone and you go down to the GCA indication, you'd see that it says 40 to 60 milligrams daily until remission, but you'd see the higher dose is only like mainly used if like visual symptoms occur, which they can in GCA. So just check what dose you'd use. So in this case, I'd use a lower dose, so 40 milligrams once daily and oral. Whereas GCA in treatment summary. So you might not find GCA in treatment summary, but what you can sometimes do is, one second, just go here. I think in treatment summaries, there's a section for corticosteroids. Yeah, so corticosteroids, inflammatory disorders. And if you just scroll down, you should be able to find like giant cell arteritis are always treated as corticosteroids. Sometimes what else you can do is if you know the condition, um, you can sometimes just type it in on the BNF search bar. I'm not sure if this will work, but okay, maybe that didn't work. Well, sometimes you can type in the condition on the BNF and it'll bring up like where it's mentioned under indications in the drug. Just go to any questions about this one? You can type giant cell arteritis, temporal arteritis, and sometimes they'll bring it up. Sometimes if the exact thing, if the exact term isn't like matching, it won't always bring it up, but you can try search it and sometimes it will bring it up for a lot of conditions. Let's move on to the next question. Yeah, got a few answers in the chat there. So yeah, so ramipril is the correct option. So well done to all those who got that, or any other ACE inhibitor or angiotensin receptor blocker would do here. Yeah, just make sure like in questions like these you don't get caught out by like little things like the age might trick you into thinking it's a calcium channel blocker, but if you look at the past medical history, you'll see he has type 2 diabetes, and that would be an indication for giving an ACE inhibitor rather than the calcium channel blocker. You'll see that the dose range again. It says 1.25 to 2.5. Anywhere between there's fine. In elderly people, usually we start with a lower dose and titrate upwards. So that's why I put 1.25 milligrams, but 1.25 or 2.5, both equally valid answers, and would get you the full marks in this scenario. So is the hypertensive flow chart on the BNF anywhere, or is this just one? So if you go to on treatment summaries, there is it's a treatment summary for everything, but there is one for hypertension. I believe it's this one. So yeah, if you go here and you scroll down, you'll eventually find it where it is. So yeah, you'll find it here. So hypertension with type 2 diabetes in all patients, any age. And you'll see like step one, offer an ACE inhibitor and ARB. And if you know what they are, then you can just pick one and just go with it. You can pick any other, you can pick ramipril, you can pick any angiotensin receptor blocker as long as the indication's hypertension. No worries, that's fine. So yeah, again, if you're in treatment summaries, just if instead of scrolling to say save time, you can just control F and just go straight to it. That's why I say it's such a good shortcut to save time. That's good. Let's go to the next question. So moving on to prescription review.
Can I just check what the EGFR was meant to be on this question, Moz? And I don't think it's there. It just says mils per min. Are we just assuming it's over 60?
Oh, yeah, just assume it's over 60.
Fab, thank you.
Yeah. Sorry, my bad.
No worries, it happens.
Got one answer. So I'll just move forward. So in this case, so yeah, so it's for confusion, it's tramadol, diazepam, and oxybutynin, for confusion. And for the one prescription that's been prescribed wrong, it's furosemide. It's prescribed as nightly. It should be sometime during the day. And I'll just go through why. So oxybutynin is usually like an antimuscarinic. It's usually given for like urinary incontinence. Antimuscarinic drugs are notorious for like causing confusion in the elderly and should be avoided if possible. Tramadol is an opioid. It's like an opioid and an SNRI, and that's also known for causing confusion in the elderly. Diazepam is a benzodiazepine, and benzodiazepines are known for causing confusion in the elderly. Um, uh, and in terms of furosemide being the wrong prescription, it's not good to prescribe it at night just because it might lead to like especially with elderly people, like increasing the urge to urinate in the middle of the night. And often like when the old people are going to like urinate in the middle of the night, they often it's dark, they're groggy and they're going and falling, and it leads to like increased risk of falls, and then that leads to like more adverse outcomes such as like hip fractures and NOFs and all sorts of other things that would be avoided if they weren't getting up in the middle of the night to go pee. Um, yeah, 1 second. So what you can do here is if you just want in terms of prescription review, so what you if you want to look at confusion, so confusion is listed as a side effect in these medications under their side effects, but you can use that and or thing here as well. So if I go to the BNF, when we go here, so you can just do confusion as a side effect, and in brackets you can put in all these drugs. I'll just do this quickly. So if we do that, you can see that it brings up confusion highlighted in the oxybutynin, and if you click on oxybutynin, it'll take you to here, and it'll show you that confusion. It's although it's rare, it's more common in the elderly, and it's listed there. And it comes up under other drugs as well. It comes up under tramadol, and it comes up in diazepam as well. So very quickly you can be sure like it's DEM3 and none of the others I mentioned. So you can be pretty sure it's DEM3. Alternatively, you could go into each one and check them individually, but that takes more time, which is why I often advise that. It's up to you, but I often left prescription review till the end just because it can be time consuming. And in terms of like approach to like prescription review, I'd always try and go through in like a systematic. So check the indication, check the dose, check the frequency, check when it's given, check if there's any contraindications, if they're like in renal impairment, is any of them not safe? So that's the way I'd kind of go through them. Just go back here. Just go to the next slide. So yeah, just a few tips to give. So there's a few like drugs that it's good to just know on the top of your head that'll just sorry, how should we find that? So it doesn't come up when you add. So what you can do is you can go to the individual medication monographs and control F and type in sedation or confusion, and it should come up under the side effects. The section B for prescription review. Is there any shortcuts or way to speed that bit up? Not really. So you kind of do have to look through like each drug, check if it's prescribed correctly. Sometimes just like knowing common doses and things like that might help you speed up a little bit, but it is a time-consuming like question type. And there's not really like a shortcut or way to speed that up. Um, so just in terms of some like information, so just check dose. So some of the prescription review questions, it'll be like a dosage error. It's good to know like a few drugs that are usually in micrograms instead of milligrams. So levothyroxine is always in micrograms rather than milligrams. So if it's in milligrams, you know it's like wrong. Tamsulosin, digoxin, naloxone, those are usually in micrograms. Check timings as well. So morning, diuretic steroids usually given in the morning. Statins are usually given at night because that's when most of your cholesterol metabolism happens. Um, like insulin and Creon, which is given for pancreatic insufficiency, that's usually given with meals. And then sometimes a really common one is like methotrexate, it's given daily instead of weekly, and bisphosphonates as well. So just check those as well. Um, so in terms of drugs that are like likely to cause falls, you've got your benzodiazepines, antidepressants, so your tricyclic antidepressants, and SNRIs, monoamine oxidase inhibitors, antipsychotics, um, opiates, antihypertensives, because they drop your blood pressure, more likely to lead to like postural hypertension, and anticholinergics. With anticholinergics, it's one of those ones where one might not increase your risk of falls, but if you've got like many together, it can greatly increase your risk of falls. So it's not that relevant to the PSA as per se, but there's a great thing that you can use in practice called the anticholinergic burden calculator. So I'll just show you guys this. Uh, oh, there it is. So yeah, so what you can do is you can type in like different drugs. So when you like doing like prescription reviews and things, and it'll bring up like what their like anticholinergic burden is, and the more like the higher it is, the more like the patient is at risk of like confusion, falls, and death. So we often use this a lot when doing like prescription reviews to just calculate like what medications are like increasing like a patient's risk of falls or anything like that. So it's just called the ACB calculator. Again, some of the ones that might be like most likely to cause confusion, opioids, sedatives, so like your even like Z drugs like Zopiclone, and anticholinergics. In terms of like drugs that are likely to cause constipation, opioids, so morphine, causes constipation. Iron, people who are like anemic and taking iron that can cause constipation. Anticholinergics again can cause constipation. Sometimes there'll be like continued, like which drugs are continued if current illness. So make sure like steroids are doubled. Um, and which drugs like you stop when there's like concurrent illness. So metformin, you stop. Statins, you usually stop. And SGLT2 inhibitors such as like dapagliflozin or I can't say it, but cangagliflozin, usually stop during concurrent illness in hospital. In terms of like drugs that are like, so you don't have to learn all these. It's just good to have a few like at the top of your head. When you're doing prescription review, just so you can quickly rule those out or rule those in, or you can just quickly tick them. Um, Hypokalemia, look at your diuretics, those are your main culprits usually for hypokalemia. Steroids. For hyperkalemia, you got your potassium sparing diuretics and your ACE inhibitors, so you like ramipril, very likely to cause hyperkalemia. In terms of hyponatremia, you've got your SSRIs, opiates, and omeprazole. Just watch out for drugs that are like likely to worsen Parkinson's. So watch out for like antipsychotics or antiemetics. So like metoclopramide is a big no in Parkinson's, and myasthenia gravis like beta blockers. But a lot of this information you can find in the BNF. But sometimes if you just have this on the top, at the forefront of your memory. It'll just save you a bit of time. So yeah, so you've got your like potassium sparing diuretics, so your spironolactone. So use carefully in patients that also take ACE inhibitors, as you can like precipitate hyperkalemia. Um, you got your thiazide and thiazide-like diuretics, so you're like benzoyl thiazide or indapamide. Those cause hypokalemia, hyponatremia, and sometimes impaired glucose tolerance. Because they usually, yeah, so that's them. And then you've got your loop diuretics, so furosemide, bumetanide. Those can cause hypotension, hypokalemia, hyponatremia, hypo everything basically because they block the sodium potassium chloride transporter. So I'll just move on to this question now. Planning management. Yeah, pop your answers in the chat when you're ready.
Can you see the chat now, Mosin?
Yeah, I can see it now.
Oh,
Thank
brilliant,
you.
fab.
Cheers. Yeah, aspirin. Yeah, aspirin 300. So this is one of those questions where it's careful to where it's important to just look at where the location is. So she's at her GP. So I think one of you said that you said aspirin, but you said may add antiplatelets. So the usual like ACS pathway for STEMI would be like dual antiplatelet therapy, but in GP, yeah, you might only have like aspirin available before you call an ambulance to take them to a centre that has PCI available. So it'll be aspirin in this case. And just if you're unsure, you can just quickly look as well at the page for aspirin, and it'll just tell you what the management of STEMI is. Just aspirin 300, just chew it. But can I move to slide? I'll come back to the slide at the end. Um, and I'll come back to that in ish. Got another one here. we've got a few answers here. We've got people saying sodium bicarb infusion, amiodarone. I think this question's quite tricky, especially because you have to dig quite deep into the BNF to find the answer, but I'll just tell you the answer. So the answer to this question is actually active monitoring. So this will come under like tricyclic overdose. So indications for like sodium bicarbonate infusion are usually like acidosis or like seizures or broad QRS complexes on the ECG. If we want to like find where this information would be on the BNF, we would go to treatment summaries, uh, poisoning, emergency treatment, and then we would go to, I'll just type in sodium. Scroll down to it. Where is it? Tricyclic. Yeah, yeah. So I'll just go here. Second. So yeah, so strongly advised in hospital. Usually, sodium bicarbonate infusions only usually given when there's like severe arrhythmias or like you've got like prolonged QRS duration. So it doesn't explicitly say that active monitoring is the correct choice. But at this point, you kind of just go off this information and see what the best option would be. You can see like from the clinical information, although the patient is slightly tachycardic, he's mostly stable. He's just got a bit of blurred vision, but otherwise he's relatively stable. So in this case, you just actively monitor. So I just made this question quite hard on purpose just to illustrate that the answer might not always be there, and you might have to just use your like clinical reasoning a little bit, and just look at the other answers. So sodium bicarbonate is usually only given when there's like broad QRS complexes on the ECG, and it's usually avoided if possible because it messes up your acid-base balance. DC cardioversion wouldn't really be indicated here, and neither would amiodarone. And magnesium sulfate wouldn't really be indicated here either. So like the best option left is active monitoring, and in this case, it is the right answer. I'll come back to that one at the end. In elderly people, there's a thing called like the stop-start criteria. You can have a look at it, and it's basically a tool that you can use to screen like elderly people for medication to stop or medication to start. So it like basically flags inappropriate or risky medication. So long-term like benzodiazepines or like Z drugs such as zopiclone, like a risk of fracture, like falls, fractures, confusion, delirium, other things like that. For anticholinergics, they lead to like confusion, constipation, dry mouth, and urinary retention, and there's usually like a little like rhyme for that, like can't see, can't pee, can't spit, can't shit. It's a bit inappropriate, but it works to remember like the side effects of anticholinergic drugs. And then there's also like a screening tool to like alert doctors to the right treatment. For like some people are on heart failure, are they on ACE inhibitor and a beta blocker? Because a lot of the times these things are missed, or they'll be an AFib, but not an appropriate anticoagulation. And other things as well, like PPIs, they're often like associated with a long-term increase in osteoporosis. Let's go to the next question. Yep, so in this case, the correct option would be if you notice blood in your urine, you should seek urgent medical attention. So in terms of drug counseling, the most important thing with drug counseling is what is the most pertinent information to their patient. So some of the other things might be true. Some of them are just false, but some of them might be true as well. But it's a case of which is more important. So with warfarin, it increases your bleeding risk, and if patient notices blood in their urine or stool, they should seek urgent and medical attention. That'll be the most important thing to tell the patient in this case. If we just go through like the other options, you should take your warfarin at the same time every day. Yeah, it's not bad advice, but in this case, the most important piece of information you'd want to tell the patient is that it increases your bleeding risk. You must not drink alcohol whilst on warfarin. No, it's not a like true statement. Obviously they advise not to drink, but if you stay under the recommended limit, it's okay. You should avoid all foods containing vitamin K. Yes, so while eating some foods that are high in vitamin K, that can affect like your warfarin's effectiveness. But like the blanket statement that you should avoid all foods containing vitamin K isn't probably the best option thing to tell the patient. And if you require antibiotics, you'll need to stop warfarin immediately. For some antibiotics might react with warfarin, but the blanket statement that all like antibiotics will react with warfarin, and when warfarin is being used, and they just stop it suddenly, it might be dangerous to the patient. So that's not very good advice. So for drug counseling, just go with like the most pertinent advice. Got a few, got a few here. Option E is the correct one. So carbimazole increases your risk of agranulocytosis, and sore throat is one of the indicative factors of that. The other information is, let's just go through the other information. So you need your thyroid function test repeated in a week. Usually when you're starting carbimazole, thyroid function is usually reviewed like 3 months after a change in therapy. And you can find that information in the BNF under the monitoring section for carbimazole. Folic acid supplementation isn't really required for carbimazole therapy. You should know that carbimazole may affect your liver. Whilst that statement might be true, in this case, the more important information is the risk of agranulocytosis with carbimazole. And you must not drink alcohol whilst on carbimazole. It's not a must not drink alcohol. Obviously, alcohol is better avoided, or you should keep to the recommended limits. But in this case, carbimazole causes agranulocytosis, and you can find that on the BNF. One thing to note is that sometimes it's not always under like patient advice. So if you go to, I'll just go to the BNF quickly. We go to carbimazole. There's different sections here. So sometimes there's important safety information. Sometimes it's under patient and carer advice. That section's under. So here it is here. So warn patients or carers to tell the doctor immediately if sore throats, mouth ulcers, bruising. So just check this section when you're going through like these drug counseling type questions. But sometimes that information can also be under important safety information, and sometimes it can be other under sections as well, like side effects, or it can be under um, yeah, so it can be under important safety information as well. So just have a look through these different sections. Or sometimes what you can do is when you're looking at this question, for example, you can just control F um, sore throat and see if it comes up on the page. And sometimes I'll just quickly get you to where you need to be. So just a few common drugs that I've seen in elderly people. So metformin is like a very common first-line treatment for type 2 diabetes. Important thing to know about it is it's contraindicated if the glomerular function filtration rate is under 30. And sometimes like the dose adjustment is recommended if there's renal impairment. With like metformin, like the main side effect, obviously you have your gastrointestinal side effects, but the other side effect to be aware of is lactic acidosis. With digoxin, it's usually used for rate control in atrial fibrillation, but like a lower dose is recommended for elderly patients. For the PSA, always check the blood results or hypokalemia before prescribing, because hypokalemia can precipitate like digoxin toxicity, and that can lead to like fatal arrhythmias and other symptoms like visual disturbances. So you get like yellow hue in your vision. SGLT2 inhibitors, so that's like a dapagliflozin, another diabetes drug. It's like causes a risk of like euglycemic decay. So in patients who are unwell in the hospital, we always like tend to withhold like dapagliflozin for for a few days until they get better, just because of the risk of decay. So sometimes they might ask like a counseling question about like dapagliflozin, and in terms of like important information, like counsel patients on the signs of decay, so like rapid weight loss, like nausea, vomiting, pain in the tummy, like that fast and deep breathing, and ketones or like a sweet metallic taste in the mouth. Methotrexate, again, like when you're doing prescription review, often they put it as like daily instead of weekly. And then folic acid as well, to like prevent myelosuppression. And in terms of monitoring, like it'll often be under the monitoring section, but monitor like full blood count, renal and liver function as well. In metformin, like we usually withhold it in patients with like acute illness, dehydration, or if they're at risk of AKI, or like before like you administer a contrast for CT scans. Yeah, few people have popped that answer in chat. So yeah, diclofenac is the right answer here. So diclofenac's an NSAID in case you didn't know. Um, and in so you've got AKI going on here. Is creatinine's increased from 110 to 178. So just to remind yourselves of like the criteria for AKI. So if you've got like an increase of 26 within 48 hours, or like two times the baseline, then just keep AKI in the back of your mind. And in terms of like drugs, that like can cause deterioration in renal function. So you've got your DAM drugs for AKI, so diuretics, ACE inhibitors, metformin, NSAIDs, and opiates as well occasionally. Does that and/or trick work for this question? It could work for this question, but it's hard to know like what the exact wording might be. So if you yeah, it doesn't work for every single question because the search term has to be quite specific. For some side effects, like confusion, that's quite specific. But if you just type in like renal and or impairment and or AKI, and then it might not like pick it up because all that and or thing does is if that phrase is mentioned on the page anywhere, not just under side effects. So for renal, like every page has a renal impairment section. So if you type in renal, then it'll just bring up every single drug, if that makes sense. Yeah, drugs that cause nephrotoxicity in the appendix one it'll also be under there. So yeah, that's a good point actually, Mohammed. So if I just show you appendix one quickly again, so you can just type it in here. Just type in nephro. So yeah, if you just go here, drugs that cause nephrotoxicity, you can see that diclofenac's there, and then you can quickly just scroll through and see if you can find anything else. So yeah, if you look at this table, you'd be able to quickly figure out that it was diclofenac. And sometimes it might be like NSAIDs you haven't heard of, and you'll just find them in this table. We've got two questions left after this one. Any guesses? Yeah, so in this case, it would be giving vitamin K by slow IV injection. So if you just look through the choices, so adinaxate alpha is for reversing DOACs. Um, and the INR's above 8 and they've got minor bleeding. So in this case, you're supposed to stop warfarin and you're supposed to give vitamin K by slow IV. And then repeat the dose of vitamin K if the INR is still too high after 24 hours. And then restart warfarin when the INR is below 5. You could, yeah, so with option 4, you would assume that warfarin's been stopped. Whereas this in the BNF, so you can find this in the treatment summaries. So in treatment summaries, it's not on the poisons monograph, it's under oral anticoagulants. So I'll just go to it quickly. So treatment summaries, and it's under oral anticoagulation. Yeah, yeah. So you can just go to vitamin K. uh, and you've got all your guidelines here for reversal of warfarin. So in this case, got iron above 8 with minor bleeding, so stop warfarin and give vitamin K. One thing just to be aware of, sometimes you might be asked to prescribe vitamin K. If you type in vitamin K on the BNF search bar, it will not come up. And like no matter how hard you try, it won't come up. And it's caught like a few people out in the past. So vitamin K is also known by phytomenadione, and that's the name for it. So if you just type in phyto, it should come up. But yeah, this is how vitamin K would be prescribed when you're typing it in. But if you just type in vitamin K, it usually doesn't come up. Yeah, so phytomenadione, so that comes up. So that's vitamin K. That's just a little thing to be aware of. And that's come up in previous questions. Yeah, so we've got a few answers here. So we've got CK for like rhabdomyolysis risk, which is good that you're thinking of that. But the answer in this case would be serum ALT. So if you look under liver function on the atorvastatin page, you'll see that like your ALT should be measured before starting treatment with statins. And then they should be repeated like 2 to 3 months after starting on changing treatment, then at 12 months. Just because atorvastatin can be toxic to the kidney. So if you just have a look at the atorvastatin BNF page and you go to liver function, you should find it there. Sometimes you can, like, you might be sure that it might be rhabdo, but in this case, if you didn't know that it was hepatotoxic, then um, you might not have known that you need to check the ALT before starting treatment. And if it's more than 3 times like the upper limit, then you can't really start it. So yeah, it's here under liver function, I think. Sometimes under there as well. Yeah, so sometimes for statins it can cause like hepatic impairment and it might cause like a rise in ALT as well. So yeah, just have a look on the BNF page, even if you're sure, just double check because 2 things might be right at the same time. But in this case, before starting treatment, you need to check ALT. Rhabdomyolysis would be something you'd be concerned of if they came into hospital with symptoms of it. But in this case, we're starting atorvastatin rather than like an acute setting. Yeah, we've got a few answers here. Well done. So yeah, it would be serum, urea, and electrolytes. So if you go to the BNF page, in case you were unsure for Ramapril, you'll see that under monitoring requirements, you'll have like monitoring of patient parameters, and you can quickly check that it says that renal function and electrolytes must be checked before starting ACE inhibitors and monitored during treatment, just because it can precipitate hyperkalemia. If we just go through like the other answers, sometimes we can just do it by exclusion as well. Serum ACE isn't really a relevant measure in the monitoring of ACE inhibitor therapy. Measuring like it says in the primary care setting, measuring like urine output wouldn't really be practical in like the primary care setting. ACE inhibitors don't really affect heart rate, so that would really be relevant. And liver function tests don't have too much to do with ACE inhibitors. So you can kind of, if you knew that ACE inhibitors cause hyperkalemia, you can kind of guess that serum urea and electrolytes would be something that need to be measured um, during treatment with ACE inhibitors. So that's it for the questions. Thank you very much for coming, and I hope you guys all learned something and learned some tips and tricks for navigating the BNF. When we send out the slides, I'll be sending out. I'll ask Charlotte to send out like a little PDF. Me and my friends made from before, like with tips from the BNF. I'll try to send that out as well. I'll go back to some of the questions that you guys were asking about. There was that bicarbonate one that you were unsure about. I'll just quickly go back to that and just talk about the ECG findings for a second. Sorry, someone wanted to go back to slide 17 as well. You'll get the slides anyway if you fill out the feedback form. And I'll be sending like a PDF with all of this like information in like table format just for you to quickly cross-reference. Let me just find that question. Yeah, if anyone has any questions, I'll be here for a while. Just let me know. So I
I'll
think
keep recording answers as well, guys. So this will be in the recording if any of you need to shoot off. So whatever comes up next, we'll keep in the recording.
yeah. So some of you were confused about runs of like non-sustained ventricular VT. So non-sustained VT just literally means like it's there for like 10 seconds and it just self-terminates. It's usually asymptomatic and doesn't require treatment, which is why the answer in this case is active monitoring. This question is quite a hard question. Usually the questions in the PSA will be a little bit easier than this because you'll be able to find the information directly, but this was just to illustrate that sometimes you might get harder questions like this. And in terms of, I'd say, like in terms of preparing for the PSA itself, in terms of like questions, I'd say the resource that's most like the actual exam are the official mocks. Those I would say are the most like the actual exam. Um, there are two other mocks from the British Pharmacological Society. They do paid mocks, but they're really good. They're really hard. They're quite difficult, a lot harder than the actual exam. Most people find them, but they're really good for practice and getting you to look in places that like you wouldn't think in the BNF. And they're great practice as well. So if you have like 3 or 4 of you, you can split it between you, and I think it's 30 quid, so it becomes something like 8, 9 quid each, and I'd say it's worth it for the practice. But otherwise, the official mocks are more than enough. Does anyone have any more questions?